I'd like to introduce myself. I'm Antal Solyom. I presented the previous lecture what I learned from infants some 30 years ago, and now I would like to show some of the clinical applications of those concepts and findings, and the clinical experiences come from any time in these past 20-25 years. And again, I am extremely grateful for the invitation to be a participant in this lecture series, and I'm particularly grateful to Professor Umberto Nájera. So the title of this presentation is Clinical Applications of the Affect Balance Principle Based on Affect Regulation, and in this part I would talk about developmental, diagnostic and therapeutic considerations. Just to briefly review the premises that I talked about earlier, affect balance is a basic need achieved by affect regulation. Affect balance principle governs the early development of and any later changes in attachment and self-esteem and in personality functioning. The clinical application of affect balance principle means to look at behaviors in order to understand the affective dynamics, namely looking at behaviors for the affects that they express or regulate, not for clinical problems the behaviors represent, and not as problem behaviors that are to be corrected. And later in the development, of course, one would look at ideations, thoughts and wishes to understand the affective dynamics, again, for the affect they express and or regulate, not as psychiatric problems to be corrected. Many times in today's psychiatry, people are focusing on symptoms and try to treat or eliminate symptoms. This has to go much further than that. I talked about this in the previous presentation, so I'll skip it. I talked about it too, but let me just briefly review that my theory of attachment is based on the affect balance principle, and this is that the infant's experience with affect regulation determines the development of an attachment to the mental representations of persons, parts of persons, self, own body parts and activities, inanimate object. In other words, not just to the mental representation of the mother. I covered this also in the previous presentation. I move on with comparing Bowlby's and Ainsworth's attachment considerations with mine. Those theories of Bowlby and Ainsworth lack any testable explanation of how does the infant develop a sense of safety, security and protection. In other words, by what mechanism and process does an attachment develop? What does maternal attunement mean concretely? What it is based on, and by what mechanism and process does it promote attachment? Or there is no explanation what happens if the maternal attunement changes. The other statement that comes from the Bowlby and Ainsworth theories is that attunement response of the mother is solely responsible for the type of attachment that develops, and that the infant's attachment will have lasting impact on the individual personality, labeled as attachment style of the individual in current clinical parlance. In other words, nowadays those people in the attachment field who talk about people's attachment styles, and they try to categorize or define patients in terms of their attachment style and how that would influence their response to therapy. So one of the books by Clinton and Sipsip, both are psychologists, entitled Attachments, Why You Love, Feel and Act the Way You Do, is based on Bowlby's theory. And they interpret Bowlby as stating stable and self-reliant personality is built on the confidence in the unfailing accessibility and support of attachment figures. They talk about attachment system that explains the principles, rules and emotions of relationships, and they talk about attachment styles, which are responsible, which are relationship rules formulated in early childhood but can be reshaped later. So these clinicians already recognize that the attachment styles can be reshaped. My comments about this is that the concepts and terms of confidence, attachment system, attachment style lack the underlying mechanism of the dynamics. In my view, the mechanism is affect regulation, which gives explanatory power and enables deeper and more detailed work in therapy. In contemporary clinical research and practice, attachment seems to correspond with affect regulation without the recognition and benefit of it. So my experience is that when people talk about attachment or attachment style, I can comfortably and more precisely substitute that with affect regulation. Bowlby's stages of separation and loss are discussed in this way that, of course, goes through the protest and despair and detachment, and the recovery from separation and loss is to eliminate the attachment figure and thereby eliminating the negative feelings that are associated with the loss. They talk about replacement defense, which is walling self off from the attachment figure, developing a callous self, and replacing things for relationships. Instead of reaching out to anyone for emotional comfort, they say the individual relies on herself and on material things, which may lead to addictions. Of course, this emotional comfort that they talk about, I would call it affect balance. My comments are that besides the description of possible grief dynamics, this description also identifies what has been lost and needed, the emotional comfort, which I call affect balance. However, it is implied that emotional comfort can be had only through caring people, and that relying on oneself or on material things is pathologic. In my view, the re-establishing of a positive affect balance by self-reliance or by the use of material things may be a constructive, healthy way of coping. It is well taken, however, that reliance on material things may deviate to drug use and addiction, which is, of course, a maladaptive coping and maladaptive affect regulation. So here is a case that impressed me a great deal. Paulo was 2 and a half months old when I saw him. He spent his first year in the care of his emotionally disturbed mother. Then he was taken away from the mother and put in a foster home. He was in a stable foster home for the past 18 months. In other words, the first 11 months was in his mother's care. The past 18 months were in the stable foster home, but was seen as an unmanageable, aggressive child. he took many medications because he saw many people and diagnosed from ADHD to seizure disorder to psychosis, everything. And of course got medications for those supposed illnesses. The foster parents had given up on him, but the DSS wanted me to see him as a last resort. Now this was somewhere in Upper Michigan, it happened at that time, and the DSS was apparently aware of my work by that time, and also I have to say that at that time, how these DSS people might have known what we were doing was that with Dr. Nahara at that time we had some seminars, teaching seminars for Department of Social Services and these kind of government people who we invited to come from any part of the state, and the purpose was to try to educate them about early childhood development, because the concern was, and Dr. Nahara was particularly concerned about the daycare arrangements, what the daycare meant for the early development of children, and so we wanted to, and Dr. Nahara wanted to educate these people, maybe social workers for the most part, in the government system, to understand what the concerns are and what they have to be mindful of when they deal with these little kids, particularly in terms of certification of these daycares, because that was the issue. These people were certifying certain programs that this is a legitimate or acceptable daycare, and the purpose was to educate them about this, what kind of things they should keep in mind. So probably that was a way that they knew about me. So anyway, from northern Michigan, the DSS said, well, take this kid to Dr. Solyom and before you give up on him. Before the evaluation, at my request, he was taken off, namely Paul was taken off of all of his medications, and I used my infant clinical assessment procedure to evaluate him. I was impressed by his inquisitive and persistent manipulative exploration and mastery of tasks. He did enjoy the interactions with me during the developmental testing, but showed very shallow attachment to the foster mother. It turned out, by further questioning, that many exploratory and mastery activities were prohibited and punished as bad behavior in the home. This made him feel that he was not understood, not valued, not lovable, which of course increased his anger and distress. So the formulation is that the foster mother and her family interfered with Paulo's attempts at autonomous affect regulation by exploratory and mastery activities. Paulo has not experienced the foster mother and her family as reliable affect regulators. Instead, they often made Paulo experience negative affect balance. He was at risk of developing a damaged sense of self and a negative self-esteem because his attempts at autonomous affect regulation were often thwarted. I told the foster mother at the end of that session that Paulo had very good cognitive capacities, was neither hyperactive nor psychotic, and needed no pharmacological treatment. However, he very much needed his exploratory and mastery activities to cope with the memory and consequences of his negative affective experiences in the past and in the present, to be able to feel better about himself. The foster mother was very receptive. From that point on, Paulo received no medication. And since everything went well at home and they lived far away, the foster mother was reluctant to make the trip. And she saw no problems. Finally, I was able to see him for a follow-up visit only 7 months later, when he actually was 3 years old. His progress in every area of functioning was very good. The foster mother must have helped his affect regulation well, as Paulo manifested a very strong and secure attachment to her and a confident, positive sense of self. It was remarkable to see that the positive experiences and feelings have been mutual. The foster parents were about to adopt this formerly incorrigible child. The drastic change in attachment was the outcome of a single session in which his problem with affect regulation were identified at 2 years, 5 months of age. It also shows that attachment is not carved in stone, but changeable by affect regulation. Another case talks about disorganized behaviors in preschool children. Joe, at 4 years of age, is in pre-K. His mother is desperate because he has become very aggressive, very oppositional and disrespectful toward her, does not accept limits, demanding, impulsive, and when he cannot get or do what he wants, he throws things at mother and assaults her. In my office, he acted as if he wanted to provoke his mother by turning chairs over and shoving books off the shelves, etc. His behavior also implied considerable distress and the need to be in control. Mother constantly reprimanded him and threatened punishment. Joe showed no affection, but hostility toward his mother. Yet he complied with her in coming into the office and leaving. He manifested these severe aggressive, destructive and oppositional behaviors only at home or when his mother was present, like in my office. He had no such problems in school. He followed the rules and what the teacher told him to do and got along with his peers. So it seemed to me that Joe's mother was unable to help his affect regulation and had even interfered with it by her disapproving and controlling attitude, as she constantly reprimanded and threatened him with punishment, even in my office. Due to her own apparent emotional difficulties, the mother was unable to be empathic and to create such an emotional environment that would have made Joe experience her as a reliable affect regulator. On the other hand, Joe must have experienced the pre-K environment and the teacher as predictable, steady, not controlling but supportive of him and supporting him in maintaining a positive affect balance. Joe's diagnosis was, by me, attachment disorder disorganized due to dysfunctional mothering in a chaotic and inconsistent family life. Recommendation was mother-child relationship therapy in order to help mother to develop the capacity to recognize and appropriately attend to Joe's affective needs, and intensive in-home therapy could best accomplish this. Another case was Tim, who was also 4 and also in pre-K. His mother is desperate because he has been kicked out of pre-K and could not return until he got help with his destructive and assaultive rage episodes. The rage episodes, meltdowns as people call it, occurred unpredictably also at home. But mother was able to hold him for as long as it was needed. No babysitter would care for Tim. Mother had to leave her job to stay at home with Tim. In my office, Tim showed interest in working with me on paper-pencil tasks briefly. However, his restlessness and disorganized and partially destructive behaviors reflected his disorganized thought processes and impaired impulse control. He also showed low tolerance for frustration. He showed helpless regression by burying his head in his mother's lap and begging her to leave the office. The frequent and protracted negative affect balance was beyond mother's control, and Tim could not experience her efforts as providing effective affect regulation. This was a psychotic disorder that the mother herself recognized. She was convinced that this child was psychotic. Of course, there was an attachment disorder, disorganized, and some developmental delays both in cognitive and social areas. So treatment was antipsychotic medication and day treatment support in pre-K. The day treatment support means that from our agency where I have been working recently, there are staff who are placed in schools and work there to help the children who have behavioral problems, so that if there is some difficulty, then this day treatment person could take care of it or help the children reconstitute or get over a particular problem. But these people are mainly to have behavioral problems. But anyway, this kind of a day treatment support was added to the pre-K environment as part of his treatment. The mother was elated. She told me, "You gave me back my son." Secure attachment to mother was also an outcome, as she could be experienced as affect regulator by the child once he was not in a psychotic state. Outcome was also that Tim was readmitted to the pre-K and the mother could return to work. Now, this is an adult woman who was getting married and needed an affect regulator. Ms. B reported in her psychotherapy session that she has felt depressed as she was trying on her wedding dress. She was missing her deceased mother. She tried to find a female friend as a substitute, but could not find anybody available, and she cried in the session. She was unable to evoke her mother's image, and her intense sadness had an almost panicky quality. My formulation was that Ms. B's unsuccessful search for the specific affect regulator, her mother, caused a marked negative affect balance. She couldn't find other means of affect regulation, so she couldn't find other means of affect regulation either, besides what she wanted, namely the mother, which threatened to overwhelm her ego functions as well. My intervention was that I offered myself to be the affect regulator mother by asking whether she had tried on her dress. She said no, but she was going to do it after this session. I asked her to describe it to me. She again started to sob, but proceeded with a very detailed description of the dress, during which a gradual but very marked positive shift in her affect balance became evident, which culminated in smiling. Sounds elegant, I said, with the aim of being empathic with her pleasure and pride in her dress. Her smile grew wider, she wiped away her tears and said, "I thought that too." The outcome within that session was that now, as she reached a positive affect balance and better organized ego functions, she was able to reflect on how her mother was often unavailable to her emotionally, and that at the weddings of her sisters, mother was anxious and depressed. So she had ambivalent feelings about her mother's presence at her wedding. She couldn't be sure whether her mother would be able to be an empathic supporter. Her mother likely suffered from chronic depression and could not be a reliable affect regulator. Miss B's attachment to her must have been anxiously insecure, and she had an insecure sense of self and couldn't trust her own judgment about the wedding dress. The conclusion is that, in my opinion, this vignette suggests that it is appropriate to support ego functions like affect regulation by introducing or making available functions that are missing at a particular therapeutic situation, as that may open avenues to insight. The possible criticism that my intervention was that of a seductive Oedipal father rather than a pre-Oedipal mother can be rejected by the outcome. Let's look at some of the diagnostic aspects of the affect balance principle. The clinical application of the affect balance principle means to look at behaviors and ideations for the affects they express and or regulate, not as behaviors or ideations to be corrected. The diagnosis of oppositional defiant disorder is meaningless, in my opinion, by simply listing a group of behaviors that express anger. When I hear people say this is oppositional defiant disorder, I say this is an angry child. The meaningful treatment starts with the affective dynamics. What is the anger about? How has this negative affect balance become chronically entrenched? What affect regulators, internal or external, are missing? What means of affect regulation would bring about affective improvement and a positive affect balance, and thereby lessening and elimination of pervasive angry behaviors. The diagnosis of conduct disorder is also simply describes behaviors that often involves substance abuse or antisocial behaviors. The treatment requires, again, the understanding of the affective dynamics through the consideration of the affect balance principle as seen in clinical vignettes that I will talk about in context of substance abuse. Some developmental issues where the affect balance principle might be relevant. The basic conclusion of this segment is that preschoolers with good self-control become healthier and wealthier as adults. The first such test that I'm aware of was the Marshmallow Test in the 1960s. And Walter Michel, a psychologist, put a marshmallow on a plate in front of 4-year-olds and told them that the marshmallow was theirs, but if they waited to eat it until he returned, he would give them a second marshmallow as a bonus for waiting. He left the room, and 1/3 of the 4-year-olds were able to wait the entire 15-20 minutes before he came back. 14 years later, when these 4-year-olds were about 18 years old, the grabbers who couldn't wait, had to grab the marshmallow, had low self-esteem. Of course, these are statistical data and not individual people, but statistically, the grabbers had low self-esteem, were stubborn, easily frustrated, and envious. The waiters, who had more self-control, had better coping skills, were more socially competent, self-assertive, trustworthy, dependable, and academically more successful. My view is that the ability to delay gratification was a better predictor of future success than any other measurement. Sorry, this is not my conclusion. My conclusion is that it shows the importance of affect regulation. The conclusion that the ability to gain gratification was a better predictor of the future success than any other measurement was the author's conclusion. I just add that it is about affect regulation. 40 years later, when these people were 40-some year old, and 60 of them were still available to be retested, they were to perform 2 versions of a computer task, and Michel was among the authors by that time, an older gentleman. This all happened at Yale University. The task was to press a button upon seeing a male or female face with neutral expression. This was the affectively neutral stimulus. The other task was to press a button in response to a happy or fearful face. The happy meant rewarding, and this was the affectively charged stimulus. In this affectively charged stimulus version, the waiters, who at 4 years of age were able to wait out the time before Dr. Michel returned, were much better than the grabbers at not pressing the button when the smiling face flashed on the screen. The grabbers, now this time they were able to map the brain also, so these 40 years old underwent some PET scans and things of that sort. And the grabbers had more activity in the deeper regions of the brain associated with pleasure, desire, and addiction, especially in response to happy faces, which offered them a reward, basically. But their deficient behavior control is specific to alluring or rewarding stimuli. It is not like in ADHD when there is a general impulsivity and or global discontrol. It was very specific when it had to do with the stimulus that offered some reward or implied some reward. The waiters, on the other hand, had more brain activity in the prefrontal cortex associated with behavior control, particularly in cases of affectively charged stimuli. So the difference was the response to affectively charged stimuli, not other kind of stimuli. So my view is that since the behavioral discontrol is affectively driven, it has to do with dysfunctional affect regulation. Another study was the Dunedin multidisciplinary health and development study. This also was published recently, and it was carried out in New Zealand, in Dunedin, but the Moffitt and some of the staff were from Yale University. They made an arrangement for the study in New Zealand. So 1,000 children were followed from birth to age 32. And children who showed early signs of self-mastery were less likely to develop addictions or committed crime by adulthood. Children who at age 3 became easily frustrated, had difficulty waiting their turn in line, or lacked persistence in performing tasks or reaching goals were 3 times more likely to become poor, addicted, single parents, or to have multiple health problems as adults compared with their better functioning peers. In a cohort of 500 sibling pairs, the sibling with lower self-control had poorer outcomes despite shared family background. They also concluded that the outcome of these studies was independent of intelligence and of social class. My view is that better self-control in early childhood implies better affect regulation that leads to better adaptive personality functioning and health and success. Another study, the marshmallows and grit. The concept of grit entails perseverance, self-discipline, hard work, creativity. This is the work of Seligman and Duckworth. That accounts for 75% of job performance. So these authors say that these qualities of perseverance, self-discipline, etc. are 75% responsible for the job performance of people, and only 25% depends on IQ. Self-discipline outpredicts IQ for academic success by about a factor of 2. Grit basically means high persistence and passion for an objective. The grit and intelligence are completely independent traits. I would consider it affect on the one hand and cognition on the other. Schools and parents should focus more on developing grit instead on intellectual or other abilities and aptitudes. That is their conclusion. Persistence in the accomplishment of an end distinguished the most successful from the less successful by another study of Thurman. Critical factor in giftedness are ability, creativity, task commitment, i.e. perseverance, endurance, and hard work. This is another conclusion by another author, Ranzuli. My view is that persistent passion and commitment is built on affect regulation. So, in the next lecture we will continue with the clinical application of the affect balance principle as it relates to substance abuse and addiction. Thank you for your attention.